Hello, I'm Linda Worrell, and I am going to present a summary of our ICAP research to date. And then in a later video, I'm going to talk about some of the practical lessons that we learnt via running our own ICAP. So first of all, just to reiterate that this, the way that I see these videos being used is sort of a bit of an introduction to ICAPs, and so that people can sort of get an idea of why we've been running them and how to actually set something up. So first of all, what is an intensive comprehensive aphasia program? We did a survey back in 2012, 2013 of, and we found a worldwide survey, and we found 12 ICAPs at that time. And the commonality was that they provided a minimum of 3 hours of daily treatment over a period of at least 2 weeks. These ICAPs used a variety of different formats, including individual and group therapy. They target both the impairment and the activity participation levels of language and communicative functioning. So this, the concept of comprehensiveness is not only embedded in the full range of the ICF, but also that there's different formats, individual and group therapy as well. And the other thing is that it includes patient and family education, and that there's a cohort. People start and end together. So there's a definable start and end date. So we found that on average there were 6 people with aphasia attending each ICAP, and that ranged between 3 and 10, and it provided an average of 4.75 hours of service per day, but that ranged also from 3 to 7 hours, and it was between 3 to 6 days per week. So over an entire ICAP program, a person with aphasia received between 48 and 150 hours of service. So that's probably a considerable dose for most people. Before I move on to our ICAP, which is called Aphasia Lift, just want to sort of note that a second survey of ICAPs worldwide has been completed and is currently being written up by Miranda Rose and her team. So our ICAP was called the Aphasia Lift. We decided to start it really because Professor Dave Copland and I sort of said, well, why don't we just throw everything that we know that works into a program? And you know, that concept of particularly of joining up the impairment and the functional side. So it was like a boot camp, and LIFT stood for Language Impairment and Functioning Therapy. And as I said, it was like a boot camp, and we developed ours in 2011. And I must admit, that the first program we ran was bordering on chaos at time. No, it was very hard work for everybody concerned. We had a lot of people at UQ who were staff or PhD students or postdocs who were involved in the program. So we were very grateful to everyone who gave up their time to start the new ICAP. Amy Rodriguez was a postdoc at the time, and she wrote up 3 programs. We run 3 ICAPs, and really sort of looked at the therapeutic effect of our ICAP. And that was published in 2013 in Aphasiology. So the aim of that sort of study was to determine just the therapeutic effect. Was there any effect of our ICAP on language impairment, functional communication, and communication-related quality of life? We used a simple pre-post group design, and as I said, we had had 3 cohorts go through by that time. And the first one we did was 20 hours per week, 5 days a week over 2 weeks. And some people said they wanted more. So the second lift we did was 25 hours a week for 4 weeks. And we settled back in between with the 3-week lift, which was 17 hours per week stretched over 3 weeks. So they were the 3 ICAPs that we were evaluating. So what we wanted to include were some values, if you like, that into the ICAP, that it was a partnership with family and friends. So we wanted to make it sort of very much a sort of an all-in together type approach. And so we used collaborative goal setting at the beginning, and we included training, support and education, not only for the person with aphasia, but also their family and friends. We were basing it obviously on neuroplasticity, principles in terms of individual treatment, particularly intensity matters, salience matters, and repetition matters. And we also wanted to take a very positive approach, almost a positive psychology sort of type lifting approach, where we created this very supportive, aphasia-friendly environment. But also at the end, we chose to have a challenge day, a challenge task, where the participants could showcase what they had achieved over the past few weeks. So our treatment was, it began with setting the goals with people with aphasia and their family members. And we had 1 hour of impairment therapy, 1 hour of functional therapy, 1 hour of group, and 1 hour of computer therapy. And these were some of the therapies that we actually used. And the challenge goal sort of was considered to be separate in some ways. And what we'd ask people was, consider something that is really your marathon, if you like. What is really the most challenging communication task that you can think of? And so over the course of the few weeks, they sort of worked on that particular goal. Sometimes, and you know, we modified it according to what we could achieve. For example, one of our participants wanted to talk about aphasia on TV. So instead of, we weren't able to attract a TV reporter or anything, so we videoed her presentation and put it on YouTube, and it's still there under Wendy's challenge task, I think, Wendy's lift. So that was that. The challenge task is on the last day. So what we do is we invite all their friends and family and their referring speech pathologists, anybody who wants to come, and sometimes we bring in people from previous ICAPs as well, and it's a sort of a party atmosphere in some ways. So in terms of results, in the literature prior to this, we had a lot, there was a lot in the Brady Cochrane review, there was concern that there was a high dropout rate for intensive programs. But we had, 95% of the program was completed, and 97% of the hours completed. So dropout's not an issue. So we recruited people predominantly who in the chronic phase of their aphasia as well. So that's possibly why there wasn't a dropout. Our program was free, but yeah, still there was no dropout. So what we found in terms of therapeutic effect was that it yielded positive outcomes across language impairment, functional communication, and communication-related quality of life for people. So individuals, some improved in language impairment, some improved in functional communication, and some improved on communication-related quality of life. There was some individual response to treatment, but, as I said, all participants improved in at least one domain. So that was good news. So we figured that was sufficient evidence to take it to the next stage. One of the, as you probably saw, one of the concerns we had was not only the dose required, that is the overall number of hours required to get that change, but also whether it required 5 days a week or whether a more distributed practice was a better option. And Jade Dignam and Dave Copland and others compared what we were doing in the 5 days a week lift and compared it to a more distributed 3-day-a-week lift. So it was exactly the same dose, but it was distributed differently. So the 3 days a week approach was over 8 weeks, and whereas ours 5 days a week was over 3 weeks. So what they found was that sort of the 3 days a week, which came to 6 hours in total, had a better effect, a better outcome on naming, and all the other outcomes were pretty much the same. So and that sort of you would expect that based on theories of cognitive rehabilitation, because learning requires some consolidation between the sort of practices. So we therefore moved our LIFT program to 3 days a week. So yes, it's now 3 hours a day, 3 times a week over 8 weeks. The other program that I've had a lot to do with is I visited the Rehab Institute of Chicago, as it was called then. It's now called the Shirley Ryan Ability Lab, and and I've also helped supervise Edie Babbitt's PhD. And if you see on this is what Edie was able to find by evaluating their past 74 participants who had completed their program in Chicago. And I think the interesting thing about this one is really that sort of level of improvement overall. So you look at the WAB AQ, and it's gone from an average of 49 to 57. That's an 8-point change on the AQ. So that is incredibly impressive, I think. So, some of there's improvement across the board. This again is a pre-post sort of study. Their improved confidence, the communicative quality of life, the caregiver says they're improved. the person with aphasia says they've improved. So, you know, these are, I think, very sort of great changes that show the impressive results that you can get from an ICAP. The other sort of consideration is, what did the therapist think about the ICAPs? And Edie interviewed the therapists, and these were some of the themes. And I think this is useful just to prepare you for what it's like to be a therapist on an ICAP. So they talked about this intensive therapy model as giving the therapist the ability to go into depth in the treatment program and, you know, and the person's profile. It gave the therapist just a different view of aphasia therapy. But probably on the really nice positive side of it was the rewards that the therapists reported. They liked the learning and support they received from working alongside other therapists. You know, we tend to do it alone in our clinic room, and that sort of learning and support environment of the therapist was really useful. The other thing they reported was just seeing the progress of patients. So, you know, I think that what we see sometimes when it's once a week, for example, is we don't really see the changes, but when you do it intensively, you really do start to see the changes. So also the relationships that they built with the people with aphasia and their family members, and seeing those relationships develop between people with aphasia and family members, they felt that as being very rewarding. However, on the other side of the coin, they talked about the challenges of being a therapist on an ICAP. The time that they actually spent doing therapy and, you know, sort of even preparing for therapy was very hard on them. And they, you know, some patients' characteristics were really quite difficult for them, particularly maybe people who were not engaged, or people who had behavioural issues. They also talked about the challenge of returning to their typical clinical setting, where they couldn't implement a lot of the ICAP principles. And so they found that maybe a little bit hard, but I think they sort of perhaps tried to wherever they could. The other research that I'm involved is with Megan Treadlecock on this website, and in her first study, what she found was that we did some focus groups of therapists around the world in some different countries, there were three sort of types of barriers and facilitators, if you like, that therapists reported to implementing an ICAP. So they talked about the need for collaboration. And I think that's not only between therapists, but also between you know, other agencies and that as well, and other parts of their service. And if you've got a collaborative workplace, then implementing an ICAP is probably going to be easier. The other thing is that there's possibly a need for advocacy for people with aphasia and getting the best service that they deserve. So if the therapists and that there are willing to advocate for people with aphasia, or people with aphasia themselves are willing to advocate, then that will help implement ICAPs. But also, if there's a culture of innovation in the service, then this was seen to be a greater facilitator. Whereas if there's sort of, if things have been tried and tested before and they've been involved in research or involved in changing models of service delivery, then that was a good thing. If however the service was still doing, you know, what it had done all along, then they felt it was going to be a difficult thing to implement an ICAP. So that's just a summary of the research that I have been involved in ICAPs. It's not to say it's not all of the research that is involved in ICAPs, but it certainly was the research that has informed me over the years.